Hi, my name is Jillian Faulkner, and I am an Indiana State University LPN to BSN student. This is for my community health nursing class. It is my 5th project, and we are going to discuss the topic of gastroesophageal reflux disease, better known as GERD. There are several learning objectives to achieve during this presentation. First, we will learn to state the difference between GERD and heartburn. List 5 common symptoms associated with a GERD diagnosis. Identify both medical and surgical therapies available in the treatment of GERD. Describe prevention and management techniques. Understand the risk uncontrolled GERD can place on one's health. At this time, please pause and click on the pre-test link in the comments section prior to completing this presentation. So what is GERD? Gastroesophageal reflux disease occurs when stomach acid frequently backs up into the esophagus, contributing to esophageal irritation. This irritation can present with a variety of symptoms. GERD is a diagnosed disease, not a symptom, and it requires diagnostic evaluation for a definitive diagnosis. Every patient's symptoms vary on a case-by-case basis, but many of the common symptoms include heartburn, regurgitation, atypical chest pain, dysphagia, chronic cough, worsening asthma, a globus sensation, and hoarseness, more so worse in the morning. GERD can be a lifestyle-limiting disease. So what causes GERD? It's caused by a malfunction of the lower esophageal sphincter known as the LES, which is the body's natural barrier to the backflow of stomach acid. The LES can become relaxed or shortened due to repeated acid exposure, which then causes it to become compromised. A hiatal hernia, which is the stomach coming up through a defect in the diaphragm, is often present in patients with GERD, and it increases the severity of symptoms related to the GERD, especially in those with a compromised LES. In our local community, we have a community-based need for a center that specializes in heartburn and its diagnostics to GERD. In our 25-mile radius, we have approximately 250,000 people in the population. Of those 250,000 people, 30,000 to 72,000 take proton pump inhibitors, also known as PPIs, for the treatment of heartburn, and 60%, which comes to be 18,000 to 43,000, are having breakthrough symptoms while on medication. That population with the breakthrough symptoms need additional testing for a definitive diagnosis of GERD. The potential diagnostic workup can include things like an esophagogastroduodenoscopy, shortened to be EGD, esophageal monometry, and an esophageal pH study. Multiple focal areas will be discussed during the rest of this presentation to cover risk factors, complications, state-of-the-art diagnostic workup options, medical therapy as well as surgical therapy, and prevention. There are many risk factors to GERD. Conditions at which you can be in increased risk for GERD include obesity, the hiatal hernia as mentioned prior, pregnancy, connective tissue disorders like scleroderma, and delayed stomach emptying, and this is because it increases the chance of backflow of acid into the esophagus due to spending more time being digested in the stomach. Factors that can aggravate or increase the acid reflux itself is smoking, eating a large meal in one sitting, eating late at night or just before lying down flat, trigger foods, commonly known as fatty, spicy, or fried foods, certain beverages like alcohol, coffee, and carbonated drinks, and NSAIDs like ibuprofen and aspirin. There are many complications which can occur from repeated acid exposure due to GERD. An esophageal stricture, which happens due to stomach acid causing scar tissue to form at the distal end of the esophagus, which creates a narrowing and difficulty passing food and liquid into the stomach can happen. Ulcers, because acid exposure causes damage to the tissue lining of the esophagus and it forms an open sore which then can bleed, cause pain, and difficulty swallowing. There is also a strong relationship between long-standing GERD and the development of Barrett's esophagus. Barrett's esophagus is a precancerous change to the esophageal lining, and it increases the patient's risk of esophageal cancer. Since 1975, the risk of GERD-induced esophageal cancer has increased 600%, and it continues to increase. As mentioned prior, Barrett's esophagus is a precancerous change to the lining of the esophagus. It can be visually seen during an EGD with characteristics of salmon-colored mucosa, but it can only be confirmed as a diagnosis with a biopsy. Barrett's esophagus is present in about 10 to 15% of GERD patients. It is not cancer, but carries a significant risk into turning into cancer. It's more common in white males in their mid-50s, especially those who smoke cigarettes. Since GERD is a diagnosed disease, there are many testing options which we rely on for accurate information. An EGD, as mentioned before, is initially performed to visualize the lining of the esophagus, the stomach, and the duodenum, and during this evaluation, the Bravo pH capsule can be placed at the distal end of the esophagus. The pH capsule records acid exposure for 48 hours and gives data based on pH values, symptom correlation, and it can determine if positional reflux is present or not. The patient carries a recording monitor with them for 48 hours and records their symptoms and activities such as mealtimes and supine periods. The capsule falls off on its own in about 4 to 7 days and passes through the GI system. Esophageal Monometry is a diagnostic motility test. This can rule out motility disorders such as achalasia that otherwise presents as GERD with similar symptoms. Monometry is an outpatient study performed without anesthesia by the Heartburn Center's nurse coordinator and takes approximately 30 minutes to complete. The catheter itself is passed through the nasogastric route and has 36 copper pressure sensors. The sensors pick up pressure readings during a swallowing series to see if peristalsis is within normal limits or not. Once GERD is diagnosed or suspected, there are many prevention and treatment options available. Lifestyle modifications play a big role in GERD treatment and prevention. Maintaining a healthy weight, eating small, frequent meals and avoiding trigger foods, staying upright for approximately an hour after eating, sleeping with the head of the bed elevated at approximately 6 to 8 inches, stop smoking and avoid alcohol use, take medications as prescribed, and if GERD is prevalent, medical and surgical options are also offered. The goal of medical treatment is accomplished through medical therapy with acid suppression, which is accomplished through medication management, the least invasive route. There are 3 classes of medication commonly used: antacids, which neutralize the stomach acids and provide a quick relief but are usually short-term; H2 blockers reduce acid production in the stomach by blocking a signal that leads to acid secretion, usually over-the-counter like Pepcid. PPIs are prescribed and they turn off the acid pumps in the stomach's acid-producing cells and are usually more effective than H2 blockers. Most are only available with a prescription at a dosage of 40 milligrams, like Prilosec and pantoprazole. If medication therapy fails, there is a surgical therapy option known as a laparoscopic Nissen fundoplication. It is discussed extensively and thoroughly with any patient that is deemed a surgical candidate. It's to be considered only if medications fail or fail to resolve/improve symptoms, esophageal cancer concerns are present, or the disease progresses to a point beyond control of medication. Regurgitation is a symptom which is harder to control with PPIs versus heartburn. A laparoscopic Nissen fundoplication involves general anesthesia, 5 small incisions, it is minimally invasive, and corrects the compromised LES and repairs the hiatal hernia should it be present. It wraps the stomach around the esophagus and ultimately stops all reflux from happening. At this time, I would ask that you please pause and click on the post-test link in the comment section to assess your knowledge since completing the presentation. There is also a link in the comments section to a free flyer. Please feel free to print as many handouts as you might need.